Hello everybody, my name is Audrey and I am a patient with uveal melanoma, and I'd like to introduce you to Karina.
Hello everybody, my name's Karina Swift and I'm the Eye Clinic Liaison Officer at St Paul's Eye Unit at the Royal in Liverpool. So what is an ECLO? I'm the link between the medical staff and the patient and outside agencies. My role, I offer emotional support to the patient and the families. I advise and signpost to various agencies that may be relevant to that patient when I do a holistic assessment on a one-to-one basis. I can offer, I go through the explanation about their eye condition in layman terms. So more often than not, when a patient is diagnosed with any form of sight loss, they normally come to me and they don't really take in what the consultant or the doctor is saying about their eye. So I really make sure that, do they understand which part of the eye is affected? Do they understand why they're having practical difficulty? And I'll go through it in layman terms. It's quite an emotional time for a patient once they get certificated. And then I go through what certification is all about, the certification and the registration side. I go to theatre with patients sometimes if they're very anxious and nervous, and I also do ward visits. Now, not every ECLO does the same across the country. It depends on how they've developed their role. This is what happens at St Paul's. So why is the post unique? Because there's only one of me in the trust. Anybody who gets certificated as severely sight impaired, which is blind, or sight impaired, which is partially sighted, they come to see me. Before COVID, everybody would see me face to face. However, due to what's going on across the world at the moment, I do all the assessments via the telephone, which I don't think it's ideal for a patient, because I think the patients like that contact. They like that face-to-face contact. However, that's what we have to do at the moment. The reason I can empathise with a patient is because I am living my sight loss journey. So I am actually registered as severely sight impaired. So I was born with congenital cataracts, severe myopia, which is short-sighted. And at the age of 15, I had an accident which caused a detached retina. So St Paul's for me, I've been at St Paul's since the age of 3, and I had my first operation with St Paul's at the age of 9. So when I came to work at St Paul's, it was, I can't explain how I felt. It was like coming home, and to work with some of the surgeons, that especially one which was, he was a professor when I started working at the Royal 6 years ago. He was my junior doctor when he did my operation. So that for me was unbelievable. So I offer training across the trust, not only to staff in the eye unit, but across the trust, because no matter who comes through our door, if they haven't got a sight, if they have got an illness and they're on any of our wards and they've got a sight condition, the sight condition becomes a secondary health issue. So what happens is the nurses, the doctors are all taking care of the medical issue, and the sight problem they may not come across. So I train all staff to be aware, to know how to approach somebody with sight loss and to make the stay better for any patient that comes through our doors. So that's why I developed a training package, and it's all practical training. So it gives the medical staff an insight to what it's like living with a sight problem. And I think that's why the role works really well at St Paul's, because when a patient's distraught or upset and they do come to see me, at least they know that this person they're talking to actually knows what she's talking about. She's actually living her journey. I always get across to our professionals or medical staff that everybody experiences sight problems is different. You will react to it differently. We could have 6, 7, 8, 9, 10 patients with the same eye condition, but you will react differently. And we need to take that on board. We should never underestimate the impact this has on an individual, because it's not what you see in clinic. It's not what, you know, what your visual acuities are. It's actually how you live once you leave that hospital, how you're managing, what happens. That's what the practical side of vision is all about. Does that answer what an ECLO is?
Yes, thank you. It does. Actually, you said more than I certainly thought you were going to there.
Okay.
And it sounds to me like when you said, and I felt like I came home, that's
Yes.
exactly the words that were going inside my head anyway. So
oh, that's lovely. Yeah. Yeah.
So thank you for that one. You talked about people having different types of problems with their eyes, you know, sight impairment.
Yes.
And
Yes.
and I thought, do you deal with it? Hold on, because you also said that you treat us as individuals, which is an amazing thing again for me to hear. But is there a difference in how you can help somebody whose sight loss is milder, less than somebody who's got severe sight loss? Does that, am I making that clear?
Yes, that's clear. No matter the reaction of any patient that gets told that they are certificated as partially sighted or severely sight impaired, the reaction is always the same. No matter what age or sex you are, I'll always get the same reaction: the shock, the guilt, the fear. Will be able to cope, etc., etc. It depends on an individual how they are as an individual, how they cope generally in life. And I always think, is your glass half empty or is your glass half full? Yeah, and it depends on that actual person, and also the network of support around them is a biggie as well. So when you say, do I offer more support to one particular patient as another? No, I would like to think they get the full Karina, but it depends on them as an individual. And also it depends on their eye condition, because each eye condition has the different practical difficulties. I would probably advise, if you come up with a problem you're having, for example, you're struggling, you can't understand, you put your glasses on, you can't understand why you can't read, I would look into that and go through that with you. And probably, I am a low vision therapist trained as well, so I'm quite lucky as an ECLO, because I'm qualified rehabilitation and also ECLO. So I've got like 3 hats that I can juggle about with, and know, especially if it comes to reading, give them practical advice on that. And then I'll probably refer them on to the low vision clinic.
Oh, thank you for that. That's really helpful. One more question, and that is, when I noticed that when you started the talk, you talked about both the physical problems of sight impairment, but you also talked about the emotional problems. Do you I hate this phrase, but do you signpost us? You know, would you direct me to I don't know, counselling or something if it's emotional, and I'm grasping straws here, but something like the RNIB if it was physical issues?
Yeah, that comes under my when I refer to outside agencies.
Right.
So for instance, Audrey, if you came to me and said, and we went through this holistic assessment, and I'm asking you lots of questions really about you and your practical difficulties, and sometimes that's really hard for a patient to open up to me. So I know some terminology, some phrases that I know you've not answered, and when I've looked at your eye condition, when I've looked at your visual acuities, I look and think, I know you're going to have problems doing such a thing. So I'll word it so I know I will get the best out of you on that assessment. So I will refer to the RNIB. I will refer people into the community services. So for example, we're a city hospital, so we see patients from all over the country, not just in Liverpool. But my patients from Liverpool, I would refer into the community service, which is Bradbury Fields, which is the charity in Liverpool that takes care of the blind and partially sighted people for Liverpool Council, and they hold the register. So I would send a referral to them. They would pick it up. A rehabilitation worker would then go about their duty to ring the patient. Normally they would do a home visit, and then we'd go through everything that I've put down a referral form with that patient, and that's where the registration part comes in. The registration is a card to say that you are registered as partially sighted or severely sight impaired. And what it does, the reason we have a certification is to help patients to gain access to community services as and when and if they require help and support. And it also helps them with benefits and concessions. So that's why it's very important for a patient not to think it's the end of the road and the hospital can't do anything, so they're giving me this certificate. They always feel, oh, I'm being labelled now, and it isn't that. It's just at the end of the day, Audrey, it's a piece of paper. You're still that same person. It's just a legal document to say your sight has now reached this level. Yeah. So I would always, and one of the things I would always talk to a patient, depending on their eye condition or their visual acuity, what they're actually seeing, I would sort of touch on mobility because that's quite a sore subject for patients who are going through sight loss. So I would touch on that as well. So yeah, there's lots of agencies out there that I can tap into and refer on to. A patient may need 1, 2, 3, depends on that holistic assessment on that individual.
I think I would, if my sight had been severely affected, and it wasn't, so I'm eternally happy for that. But I think if my sight was severely affected, I would be totally lost, and I can't imagine life without somebody like you helping me to get through this sea of confusion, because who would I turn to? I mean, I was a lecturer and I wouldn't be able to teach anymore. This is what would go through my mind. So how do I survive? I would be terribly upset. Who can hug me, for want of a better phrase? And here you are answering all of those questions, and I didn't know you existed.
Right.
So.
Well, when patients come to me and say, but I'll have to give up my job, I'll have to do, no, you don't. You do not have to give up your job. So you've just hit on a point saying I'm a lecturer and I'd have to give up. No, you wouldn't, Audrey. You would have things in place to help you to do your job. Don't get me wrong. I'm not sitting here and saying it's as easy peasy. No, it's not. It's not. Having a sight loss does throw its challenges. And I'm challenged every single day with my sight loss. But we do things differently. So you would probably get some electronic aids in, depending on your level of sight. If it means that you can't drive anymore, it depends on where you're driving to. You would get access to work is an outside a DWP. It's run by the government, so they provide support to people with any disability to help them to stay in their employment and to carry out your job. They don't replace you. What I mean is, it's so, for instance, I have a driver to and from work, and I have a support worker 3 days a week. So the support worker comes in, it does all the things that people who are perfectly sighted can do, just like that. For example, filing, finding a document quickly, reading if I have to go to a meeting and I need to read a report quickly. Obviously, it takes me a lot longer, so they would probably read it to me. They would go scanning for me. They would run about the hospital if I needed something taken somewhere. So anything that I struggle with my sight, they would do it for me. It works really well. At first, I wasn't so keen on taking anybody on. And bear in mind, yes, I've had sight loss for a long time. But when somebody says, I think it's about time you got support, can you imagine how I felt? And that only came in 2014.
Oh.
So that was a real big shock to me, that I'd have to have somebody now working alongside of me. And they were on a 3-month trial, and they're still with me today.
Oh, excellent.
So for you, Audrey, you wouldn't have to give in. We'd put things in place. We'd look at different things. And that's when I help people and I advise people. So I find that I have an open door policy. And yes, patients come back to me and say, oh, Karina, can I just ask you this? What did you do with this? And we've got a good relationship. The role is very busy, which is good for the hospital. The increase in workload has obviously increased. But I think that's good, because one of my things when I became an ECLO was to see everybody who comes through St. Paul who's blind or partially sighted, because I didn't want anybody slipping through that net.
No. What about the likes of me, who I'm not blind, nor am I partially sighted? I've just got what I call a dodgy eye. It doesn't see as well as it used to. Is there anything out there for us?
So when you say a dodgy eye, it means so your other eye's perfect vision.
As good as, yes.
So you're able to drive?
Yes.
Right, okay. So my advice would be to you, you should be grateful that your sight has not reached
Eternally.
the level of certification, okay? You may have practical difficulties. For example, you may have difficulty reading something, or you may become tired because your other eye is working more. You may get frustrated because you may have had perfect vision. All of a sudden you've got a reduced vision in one eye. That may cause you a problem. I would always say, talking to people when you go for your checkups, make sure you stay at your checkups. If there is anything that you're not quite sure about, or anything suddenly changes, that's when you need to go back to your local hospital, or if you're not under a hospital, you go via your GP. Unless it's an accident emergency, then you go straight to your A&E department, because there's no way I would take any chance with your eyes. No. And especially if you've got, as you say, one dodgy eye, you want to make sure that everything is staying good with your other eye. I'm talking a lot with my hands, aren't I? And I do apologise.
No, that's fine. I confess I'm sitting here holding mine out of sight.
Right, yeah. I'll put them under my bottom then.
I'm so pleased that I've had this opportunity to speak to you. And for those who will get to see this video afterwards, I think it's only fair to warn them. We've never met before.
Never met before. No.
This is our first.
I feel as though I know you, Audrey.
And I'm thinking people who come to you will feel the same way as I do right now. That
that's
so
lovely.
And I don't want to turn this into a group hug, but you are an incredibly warm person, and I think if anything had happened to me, I would want to come across somebody such as you. You're knowledgeable, but without that coldness.
That's lovely. So thank you very much.
That's okay. That's my pleasure to say that one. I can't think of anything else that to ask you, even though all of these kind of things could come in my direction if I'm not careful. Last one. Those that have monocular vision. We've talked about people who can see, and we've talked about people who cannot see. But what about the half and half? The monocular.
Okay, so halfy, monocular vision. This can happen to anybody. They can have perfect seeing eye. They could have an accident. They could have an infection. Anything could happen that they'd have a non-seeing eye. So the difficulty with that would be that if they are a driver, it used to be they had to get used to the monocular vision for 3 months, but they did change the driving. The driving standards were, it's up to you as an individual. If you've adapted to monocular vision, then you're able to drive.
Right.
Okay. So nobody's now putting a time on it. Because people react differently to things, don't they? Monocular vision would affect depth perception, 3D. You wouldn't be able to watch 3D, see anything with 3D, and pouring liquids, because you just haven't got it. You just can't do it. So it's always to be aware of that. Sometimes, I mean, you could go and see an orthoptist, which will look about the movement of the eye. They may be able to help with something, but generally it's just learning to cope with one eye, with one vision from one eye.
Okay, thank you very, very much. When I first had my operation, obviously I had to wear an eye patch, and the depth perception. Oh yes.
Yeah. I'm banging into things. I bet that's really common for you.
Yes, but I still do that one, so that's not a problem anymore. I'll get used to it.
I mean, that's quite common in my journey, eye journey, because I've no vision at all in the right eye, but I've no peripheral vision at all. So I'm banging into things lower, above, at the sides. Great. Sometimes it's great fun.
Right. Okay. Well, thank you so much for your help, and you've answered a lot of questions, I think, that people have running through their heads. And I think the most important one is that the majority of hospitals provide, if not an ECLO, then a sight loss advisor of some description.
Yes, they do. They do. It depends on which hospital. Some it's supposed to be in all our ophthalmology departments. I think that they are trying to get that, and I do feel from a patient's point of view, years and years and years ago, there was none of me when my family needed support. When I was taken in at the age of 3, there's no support, and I think it's so valuable. The one message I do want to get across is that, and I always say this to my patients, is sight loss is not life-threatening, but it's certainly life-changing. And you can do anything. You can continue with your hobbies, your interests, but we need to do it differently. And I've certainly proved that in the things I've done with sight loss as I've gone along year by year. And that's what I always say to a patient.
Thank you so much for that. And I will definitely catch up with you again at some point. I really, really enjoyed your talk. Thank you.
Okay.